also want to just let people know that I was in primary care for many, many years. And so I will bring that in when I talk about the communication of diagnosis and follow-up support for our patients with dementia. Oops. So I have no conflicts at this time. And our learning objectives for today are to describe the impact of disclosing the diagnosis of dementia to patients and their care partners, recognize the challenges amongst clinicians of communicating the diagnosis of dementia, and lastly, develop empathetic ways of discussing the diagnosis of dementia and follow up for understanding. So I'll start with this, and I usually start with most of my presentations because I think the brain is so powerful. And it's a quote from Hippocrates, and men ought to know that from nothing else but from the brain come joys, delights, laughter, and sorrows. And by this we acquire wisdom and knowledge, and see and hear, and know what are bad, what are good, what are sweet, what are savory. And by the same organ we become mad and delirious, and fears and terrors assail us. All of these things we endure from the brain when it is not healthy. And in these ways, I am of the opinion that the brain exercises the greatest power in man. So I know that we have heard some wonderful presentations today, and I will try my best not to overlap with most of it, but there might be some overlap in what we have already discussed. So this figure you might have already seen, but just the top corner in yellow, I have highlighted that while only 4 in 10 Americans talk to their doctors right away when they're experiencing any memory or thinking issues, but 7 in 10 would actually want to know earlier if they are having Alzheimer's disease and what can be done or what can they do at this time so they don't have diagnosis. So that's how important it is. I know that. So as you all know, the caution is so complicated. Just this slide makes me understand that is so complex. Along with aging, which is a big piece, there is a lot of other factors that can affect cognition. And so it's even more complicated and more difficult to provide a specific diagnosis or even a most likely diagnosis. So just to understand this, how difficult this is. Sociodemographics can affect it, lifestyle can affect it, psychological status can affect, like anxiety and depression. If somebody is going through cancer treatment, that can affect it. Some of the other treatments that we provide to people, for various reasons, even the vascular, cardiovascular disease, diabetes, even the treatments can affect it. And some of the biological factors can certainly affect, including genetic factors. So communication of diagnosis of dementia, as you all know, that it requires a lot of care, courage, competence, compassion, and commitment. And we'll go through not individually, but collectively, all of these things, which we know that it's such a difficult diagnosis, one to make, and also being empathetic for patients to communicate and to talk to their family members about it. So as far as the United States goes, the data on disclosure of diagnosis is that 80% of geriatric psychiatrists, geriatricians, see benefits of talking about a diagnosis, but only 40% do it consistently. As far as Americans go, 90%, if they're having some trouble with their memory, they want to know if there's this Alzheimer's disease. Only 6% in some studies have shown that they would rather not know the diagnosis. And it could also depend on cultures and traditions too. 50% of the patients with dementia have no diagnostic record or discussion notes in their charts. Globally, 1/3 to half of the people with Alzheimer's disease are only diagnosed, only half the time. Caregivers report that in Spain, 23%, in Scotland, about 80% of the patients had been informed about the diagnosis. And caregivers report delays about 10 months in Germany, 32 months in UK, and this is pretty much the same in the US, about 2 to 3 years of delay from first noticing symptoms and even bringing up to their clinicians and actually having a formal diagnosis. And you want to have this culturally sensitive care, talk about that, and Dr. Ellison talked about that a little bit too, as to having that cultural sensitivity is so important, especially with the diagnosis of dementia and Alzheimer's disease. So we know that Black and Hispanic Americans are disproportionately highly affected by Alzheimer's disease. So Blacks are affected about 18.6% of the time, Hispanic 14%, and white 10%. Stanford Medicine has actually developed a lot of good learning modules in ethnogeriatrics. And I'm just going to share a few slides on my recent trip to Cuba with 15 geriatricians from US and Canada. And the reason I bring it up is just to have that, cultural sensitivity and not, we all have interpreters in our clinics. And unless and until we understand, especially for a diagnosis of dementia, unless and until we, understand the complexities of their culture and all that, it's difficult to, provide the diagnosis and follow up for that. So anyways, this is, we went last month for that. We visited their clinics in their neighborhoods. And even though they did not have, the resources that we have in the US with medications, with electronic records or any of that, they were providing an amazing job to their patients. And they also have a very population that is aging. They are also seeing a lot of patients with memory impairment, and the way they were providing care was just absolutely amazing. We visited a clinic with a multidisciplinary team, and we'll talk about that in a few seconds, and how they were running it, how we run here in the US, and some of the similar things that we do here. They were just doing it with very limited resources, having cognitive training, bringing their caregivers into into their appointments and their training sessions and all that. Was just absolutely amazing. We also saw some of their social programs that they were doing, like Alison was talking about, how social work gets involved. They have some of these social programs going on in their communities for older adults, whether it's in a nursing home setting or in just a day program setting, which we also have here, these adult day centers. Again, Cuba is a very homogeneous population, and they're not in the US, so we see all the differences. So as far as the communication go, most patients prefer diagnosis. The details might differ between cultures, education, age, and sex. So it's important to know who should disclose the first-time diagnosis. And I know that, previously we were talking about, the different specialties that people see, along with primary care providers, geriatricians who might be primary care or might be doing it as a consult, neurologists, neuropsychologists, neuropsychiatrists, psychiatrists, social workers, therapists, occupational therapists. So, it's difficult to disclose the diagnosis, but it's also important that when you share, you have all the details. Primary care providers and geriatricians are probably the best to provide that kind of diagnosis because they have all the details. They know the patients very well. They know their families very well. But again, anybody can provide the diagnosis. But that first-time appointment, and we'll talk about that, is extremely important when you're providing that diagnosis. It should be an in-person appointment. You should have full attention. You should have enough time for giving them time to process it and answer questions. Encourage family members to be there. And it's also important to talk to the patients along with the caregivers, that you're modeling that to include them in patient conversations, even if they are a little bit advanced in their dementia. It's not a one-time thing. That first appointment is important. It's an ongoing process, and it should be tailored as we evolve. We also talk about having communication framework before you disclose a diagnosis, and we'll talk about a few of these frameworks and how important they are when you are disclosing a diagnosis of dementia. Try not to withhold information and not to be overly optimistic about prognosis, but you should definitely have, positive features into, how you are giving that diagnosis and how the follow-up is going to be. And then definitely summarize your visit with written documents and show that you are making follow-up appointments for continued care. So we'll talk about a patient scenario. She needs answers. That's why we are here today. So we'll have a patient named Isabella and then a clinician. So Isabella is saying, that doctor you sent me to said I have some memory problems. Who doesn't at my age? You, the clinician, is saying, can you tell me more what the doctor told you? And these statements are important because you don't want to just jump to the conclusion that, okay, I'm going to tell you, what I think, but getting that assessment as to what they have understood so far, what they remember from that conversation. Some people are anticipating a diagnosis at this appointment. Others may have already talked to other people about it. So having that perspective is extremely important. Isabella says, my daughter thinks it's Alzheimer's, but I think it's just a normal part of getting to my age. You, the clinician, is saying, is it okay if I share with you what is going on? You likely have dementia due to Alzheimer's disease. So after asking that, is it okay to share, you're asking for that permission to give this sort of life-altering news, but you want to have that short headline sentence, and that's extremely important. Naming the dementia is also important to avoid any sort of confusion. And we'll talk about it, how patients perceive it and how long they will remember it and how important it is sort of an ongoing process. So this appointment is important because you're disclosing the diagnosis, you're going to give that headline sentence. You must have all the details or at least most of the details to be able to provide that information. So you should have all the cognitive testing information, MRIs, biomarkers when available, including the CSF analysis, the PET scan results, genetic testing, and try to give as much of a concrete diagnosis as possible. So I think we talked about it. I'm not going to repeat this, that Alzheimer's is the most common, and there are other diagnoses, but as close to the diagnosis as you can, or if it's unspecified, do let the patients know that. So I would encourage most of you to just get comfortable. If you're not, most of you might already be comfortable reading MRIs, PET scans, graphs to show to people, where they are. Again, it depends on, asking the patients, how much they want to know, how much their family members want to know, whether everything should be disclosed in this first appointment, whether it's too overwhelming for them to have them come back. But people need to know, what's going on. They encourage that. They want to know all this information. So Isabella says, no, it can't be. I'm fine. Everything is fine. You and those other doctors are wrong. You, the clinician, says, sounds like this is not the news you were expecting. So like I said, it's a life-altering diagnosis. It's a serious illness. So, these emotions will come in. You want to be expecting these emotions, acknowledge them, name them if you can, before providing all this factual information. So it doesn't have to be in this one appointment. It could be in the next appointment, depending on how the patient and the family is taking. Isabella says, if I have dementia, who is going to take care of my husband? He had a stroke last year. You, the clinician, says, I can see you're really worried about your husband. Isabella says, all this it's too much. I need to get home to George. You, the clinician, says, it sounds like this is overwhelming. I was wondering if we can meet with you and your daughter in the next couple of weeks to talk more about this and how we can help. So like I said, naming the emotion, making those next follow-up appointments are extremely important. So, and you will see these patients, you have already seen these patients, we see them all the time. Different people take it differently. You see them getting very emotional, crying. They don't want to talk to you at this time at all. They don't want to see anybody else at this time, and that's totally okay. So we'll talk about a few frameworks of communication, and you may have your own that you like. You can make some of your own, but I'll share some of the studied ones, some of the validated ones, and you may be familiar with some of those, and you already might be using it. This is one from the Ariande labs that the palliative care practitioners use a lot. The Serious Illness Conversation Guide. I like it. You set up the conversation, you assess the illness understanding and information preferences. So it's like, you're going into a procedure for a surgical procedure. So you are preparing for it. You want to be ready with all this information. So you can share the prognosis too. You can share that it's progressive. You can share where we are. Again, it doesn't have to be in one sitting. It could be in different sittings. Then you explore the key topics, like what are their goals at this time? Sometimes I ask people, what makes you you, or their family members, or who they were 2 years ago or 10 years ago. What are their fears and worries? What do they fear about, especially if they're earlier in their diagnosis? They have a lot of insight into their illness. What are their sources of strength? What are their abilities? What are their disabilities? What are their trade-offs? And what the family dynamic is like. Then you always want to close the conversation by summarizing what you have heard, recommendation, and then you document everything. And then you follow up and you end with, we are in this together. We'll work with you, wherever we are, and we'll provide all the resources. Another framework is the ABCDE. Again, same sort of a framework, different setting, different ways people are doing it. People remember it, ABCDE, how to do it, advanced preparation. So again, have everything with you, you develop a relationship, you communicate well. So that's also very important to avoid a lot of medical jargon versus using plain language, what people can understand. And that's where culturally being sensitive is helpful, is what they can understand, what their reading ability is, what their learning abilities are. If they're coming in with a family member who also have some either learning disability or memory impairment, or there are other caregivers that can be involved. And then again, deal with their emotions at that time, periodically on phone calls, follow-up visits, and encourage and validate their emotions. I think that's extremely important. Another framework is called breaks. Again, same sort of scenario, but people remember it by some of these mnemonics. So having the background, developing relationship, explore what their understanding is, and then announcing this serious illness or, telling them what it is. And people, and all of us, I think, are a little bit afraid of, saying these words or with a worry of, causing more anxiety. But I think, and we'll show in a little bit some data on that it actually reduces patients' anxiety and the family members when they actually know, just like, other illnesses. And then again, kindle their emotions, summarize it. Another one is the spikes that palliative care also uses a lot, and having that mnemonic of setting up times, setting up interruptions, perception of where they are, what their understanding is, inviting to, what we have, how much they already know, summarizing some of this stuff, addressing their emotions. And then I think the important thing in this one I like is strategizing, what the future is going to look like. So it's important to, whatever framework you use, I think sticking to it, all these points is important. I think this is the last sort of framework that I talk about is NURSE, which is, again, naming the emotion. And it's, I think it's how you go in the framework is, are you going to name this first? Are you going to collect more information? Are you going to see what their understanding is? And again, respecting the patient, supporting them, and exploring, what what they want to talk about, how the family wants to talk about, what the treatment is looking like, and things like that. So this is from Dr. Barrett, and she's the chair of our neurology department at the University of Massachusetts. And she had published this short-term effect of dementia disclosure. And it's something that you are familiar with. This anosognosia is a neurological condition that people have this denial or unaware of their neurological deficit that you see in schizophrenia and bipolar disorder. And then people with this may be unable to accept their symptoms or that match their condition, even if they have a brain disorder. And 12.5 to 33% of caregivers and family members could not report the patient's diagnosis minutes after hearing it. So, we have, and we'll talk about our multidisciplinary clinic, is sometimes we have these appointments back to back, and one of us would have shared that information, and then we go in an hour later and kind of the same questions and all that as if nothing got settled in. And that's how important, this ongoing process of disclosure is for patients and their families. So what is the hesitancy in early diagnostic disclosure is we're all uncomfortable with making the diagnosis, especially in the earlier stages, because and we'll talk about it because we have hopefully some disease-modifying treatments coming on, like we heard earlier this morning, that we should be able to, try to make earlier and earlier diagnosis, even at the level of subjective cognitive impairment. And the additional hesitancy is, lack of comprehension of patients with significant cognitive impairment. But even then, patients and family members need to know the diagnosis, and it's important that we provide them with the data that we have, with the testing that we have. Another concern, like we talked about, is if we diagnose, patients will develop a lot of anxiety, depression, even suicide. And in fact, the studies have shown the opposite, that it actually declines some of the anxiety. And there are tons of benefits of early diagnosis, that patients with dementia and their family members can be involved in their own care decisions. Like we talk about, having that advanced directive and healthcare proxies and, their life-sustaining treatment information or goals of care information and all that. They can be involved in this, all this process. They can be provided some of the benefits of whether it's eating healthier or exercising, developing like these social circles, like we were talking about earlier, which the social isolation and loneliness causes. And then early pharmacological intervention that we talk about can also help in this disease progression. So the earlier we make this diagnosis, that's important. Providing that anticipatory guidance, which is this proactive counseling. And you want to differentiate that between diagnostic disclosure and this anticipatory guidance for the trajectory of the disease progression. So every time you meet them, the disease might be progressing at some level, or it may have kind of calmed down a little bit. So you can talk about that. And the most important thing is educating patients and caregivers and also clinicians about dementia, so we can destigmatize this problem. So follow-up after diagnostic disclosure, the questions from patients and caregivers: isn't there any So basically, what I was just saying is patients will have a lot of questions, caregivers will have a lot of questions after this, either at the first appointment or the appointments after that. And you want to be able to answer those questions in, whatever manner you can. And I think we should be able to answer all these questions that are here. So for treatments, we'll talk about in a second. What are some of the things that we can do now? What is going to happen in the future? Some of the prognosis and stuff that we should be able to provide them with the stuff we have. We have some cognitive enhancers that have modest efficacy, but they should be offered for patients who can safely take them. So cholinesterase inhibitors like the donepezil, rivastigmine, galantamine, for patients who don't have a lot of cardiac risk factors. There is, the studies have shown they do help with some neuropsychiatric symptoms too for mild to moderate dementia. Once you start it, don't stop it because you could regress a little bit. And then we have the memantine, which we start with moderate dementia. That's the FDA approval. Sometimes people start it a little bit earlier along with the cholinesterase inhibitors. And again, once you start it, don't stop it unless there is some contraindication to it. And then the other treatments, like earlier this morning, we went quite a bit in detail on lecanemab, which is available in particular centers. We at our institution have developed a protocol, a safe protocol with specific criterias that we are using. And we started early January with patients who are able to be provided. So I'm not going to go into the detail because we already heard this morning. Caregiver support, Nelson talked about it in quite a bit of detail. So those are some of the things that we should provide when we provide the diagnosis. So I'll talk about the interdisciplinary communication of diagnosis and follow-up that we have developed at our institution, and why it's important to have an interdisciplinary team, not obviously just for diagnosis care. Is if you have an interdisciplinary team, you can provide a more holistic and hopeful disclosure because all different teams are providing their own ways of providing care. It also reduces the negative emotional burden on an individual healthcare professional. So if you leave the diagnosis or the progression of that to, let's say, the primary care provider or maybe the geriatrician, then it takes a big toll on it, and that's probably why we all shy away from providing this diagnosis, is also because it takes a toll on that particular provider. And we see that in our interprofessional team too, is whoever provides the first time feels that burden. But then if someone goes in, right after, or maybe at the next visit, or a phone call after that, that takes away that negative toll on that clinician. It also takes away the toll from the patients and their caregivers, that it's not this singular negative event that is just going to, be a sort of a major life-altering thing for them. But there are other team members who will be helping them and can provide that. So I have developed an interdisciplinary memory and aging group with, like how Gunjan was talking about, from the different specialties, from geriatric medicine, palliative care, neurology, neuropsychology. We have geriatric psychiatry. We have actually one geriatric psychiatrist. And then we also have ambulatory medicine in this group with primary care providers to be able to come through. So what we do now with this model is we have a core group, then we have a bigger group which meets quarterly, discusses patients or other other topics. But what our bigger goal is to have this for our Memory Center of Excellence. So we can have geriatric medicine focus on the geriatric syndromes, the transition of care, the home care, palliative care can utilize the communication skills, the prognostication, the anticipatory guidance. Neurology and neuropsychology can provide the diagnostic skills, and psychiatry can have the behavioral and psychological symptoms of dementia. And then we can all work together. And you may be familiar with the Geri Neuropalliative Care that Dr. Christine Ritchie, that I have worked with closely at Mass General, has sort of given that name to that model. And that's what we are striving to bring to UMass. So this is our kind of vision of the UMass Memory Center, and most of you, or at least some of you, may already have had running Memory Center of Excellence. We are sort of in the beginning process, and that's why we're trying to build as many of the interdisciplinary professional teams as possible. And that's what we're striving to have, all these different specialties. We also have a paramedic service for home care. We're going to try to have more therapists in, if we can, along with nurse navigators and social workers, to be able to have this one centralized care for home, community, inpatient, and for primary care and specialist providers. So what we have now is an interdisciplinary cognitive clinic. We have a clinical team with the geriatrician, neurologist, neuropsychiatrist, nurse practitioner, psychometrist. So it's in the initial phases of it. We have the initial care planning done with the nurse practitioner, cognitive testing by a psychometrist, and then evaluation and management by either a geriatrician, neuropsychiatrist, or neurologist. So any one of us can provide that diagnosis in the initial stages, especially when we have all the testing available. And then as far as the geriatrician's role is, it's extremely important, just like a primary care provider's role is extremely important in providing that diagnostic disclosure, along with the other things like the anticipatory guidance, the caregiver support, the advanced care planning. And we use the 4Ms. Most of you are familiar with the age-friendly health system. I try to bring all of that in our sort of that first appointment too, as much as possible, along with the geriatric syndromes we talk about. And that's also extremely important to provide that information to patients and families, along with their primary care providers. And then what we do is then we have a team meeting after, before we are providing this diagnosis to the patient. So before that appointment with the patients and the families, we have a team meeting with all the team members from our interdisciplinary team, go over, what are we going to offer them, whether it's treatment with medications, whether it's supportive treatment, coordinating of care with the referring physician, primary care provider. And that has been, it's kind of like how oncology does, but we're trying to sort of develop that framework. And then we measure some of the metrics and outcome measures. So I've just highlighted the two that are important for this talk, the diagnostic disclosure with chart documentation, like we talked about. 50% of the people would not have any information in their charts. So we make sure that that's all documented, and the diagnosis is added to the problem list. And that's also important for the electronic data, especially if you have Epic, that can take that information and sort of bold it for patients if they go to the emergency room or any other setting, for other providers to know that they have mild dementia or cognitive impairment, so they can be more mindful of, especially for delirium purposes and prevention of that. And then the pharmacological treatment, obviously, if you're providing that, we are also developing a sort of advanced therapeutic program for these patients, for deprescribing for patients who are coming in with slew of supplements that they have either seen on TV or others are providing them for either memory impairments or other things. And then also for treatment for either it's a cognitive enhancer or whether it is the disease-modifying treatment, to be able to develop using our interdisciplinary team to provide the best treatment options. We have developed it for other treatments, and other institutions may have done that for example, for diabetes or for chronic kidney disease.